Hi, it's the 25th of August, the first video I've done for a long time. I keep meaning to do a video, but because I'm using the built-in camera of my Mac, it works much better with natural light, and usually the time I have for doing videos is kind of late at night when kids are in bed. So this video is all about the current treatment I'm having, which is a type of radiotherapy called tomotherapy. I'm having 10 weeks of this treatment, Monday to Friday, so 50 sessions, and I'm, I think, 6 weeks into it. So the first 5 weeks were for treating my right lung and some lymph nodes that were para-aortic lymph nodes, which means they're kind of down in the abdomen where the aorta, which is the big blood vessel from your heart, so goes down into your pelvis and then splits. I guess it branches into the femoral arteries that go into your legs. So it's the biggest blood vessel of the body, and because I've got cancer in those lymph nodes, it's very, very serious because it's easy for the cancer to spread up through the body, and they're hard to treat with surgery. It's a long, dangerous, difficult surgery, and surgery is basically not recommended because of cancer in other places. They thought that the surgeons thought that the benefits wouldn't outweigh the risk. So this is mainly about tomotherapy. I'm going to explain why I've decided to have this treatment. So I'm getting treatment in Japan, and in Japan the multidisciplinary team system is very uncommon. So generally you're treated for cancer or any other very serious disease just by one doctor who makes all the decisions, and that's not great. It does have some benefits, so speed is a big benefit. In Japan, when I came here 3 years ago, returned here with the cancer diagnosis 3 years ago, I met the surgeon, and he said, "Oh, you can come in for surgery tomorrow." Super quick, he makes the decision. Now I actually decided to delay the surgery for a week anyway, but everything's super quick, super easy. And it's obviously good to have one doctor who knows you gets to know you very well when you're having a life-threatening disease, or in my case, a terminal disease. So the bad points of having a single doctor, of course, a surgeon is going to be most familiar with surgery. An oncologist is generally going to be most familiar with chemotherapy. An immunotherapist is going to be mainly familiar with immunotherapy. Radiologist is going to be familiar with radiotherapy. So what I'm doing is going and meeting various specialists. Interestingly, one point I found is that the specialists who are really good are often expert in another field as well. So I'm taking radiotherapy in Shinjuku. It's Shinjuku-ku, so it's like the area of Shinjuku. It's not the city of Shinjuku. That bit of Tokyo is Iidabashi, but it's the Shinjuku Medical Center, and it's about an hour from my house. And I could have found a closer place, probably maybe 40-45 minutes away, or even less. But this guy is the top guy in Japan for tomotherapy, and as I got to know him, I found out he's actually a specialist in another type of cancer treatment as well, hypothermia. So that's using heat to damage cancer cells and to make the cancer cells more visible to the immune system, because when you heat up cancer tumours, these proteins form called heat shock proteins, and these are visible to the immune system. And there are various other benefits of heating tumours, but yeah, so I found that this specialist of tomotherapy, type of radiotherapy, so he's primarily a radiologist, is also a specialist of another advanced area of cancer treatment, just as my immunotherapist, who is considered the father of immunotherapy in Japan, he was originally a microbiologist, and in fact, I think he went to maybe Zaire or another African country to help with the HIV/AIDS crisis before returning to Japan and helping to tackle cancer here. So it's just an interesting observation. I think that in the medical world, often the real experts, the sort of the leaders in various fields, are actually experts in other areas as well. So I'm having tomotherapy, so I'm going to explain a bit about what it is. So as I said, it's a type of radiotherapy. So I'm having it because these tumours on my lymph nodes are in a place where it's difficult to do surgery. I also had the tomotherapy for my right lung. Now the tumour there would have been relatively straightforward. The surgery would have been done with a 3 centimetre incision, so that's what, 1.25 inches or something, done by keyhole surgery, essentially with 100% success of removing the tumour. But when you have surgery, it's traumatic for your body, which is unpleasant, but far more importantly, suppresses your immune system, and that means it gives the cancer a good chance to spread. Cancer sort of recognises that opportunity and goes for it and spreads. So avoiding surgery is kind of important, really, if you want to live as long as possible with terminal cancer, so stage 4 cancer to spread to other bits of your body. So I had 5 weeks of tomotherapy, going Monday to Friday, so going each day, treating 2 different sites, so the area with its lymph nodes and the tumour in my right lung as well. One session, so for one tumour it takes about 10 to 15 minutes, so the treatment itself for the 2 areas was about 30 minutes each time. So sort of had an hour-long train journey, and then waiting around to start the treatment, and then the treatment itself, and then waiting around to pay, and then an hour train journey back. So it sort of for me takes 3 hours out of the day. And now those 25 sessions are finished, and I've had 5 sessions for my liver. And the reason I'm having it for the liver is that, again, well, first of all, I had liver surgery 7 months ago, and I like to avoid it again if possible. Liver surgery is open surgery, generally not keyhole surgery, because the liver is hidden behind your right floating ribs, hard to get to. So the surgeon or the surgical team have to cut you open a lot to get in at it. So that's why I'm having tomotherapy for the liver, but also the tumour I'm having treated, which is a new liver tumour that was found after developed after the liver surgery, I guess, in the sort of over the 6 months before I started chemotherapy again. That tumour is a bit small, and also is next to the portal vein, which is the big. It's actually a blood supply for the liver. So veins go into the heart, but the liver's unique in that it's got a dual blood supply. It's supplied by a vein and an artery. I guess it's the portal artery. I don't know. My anatomy knowledge is pretty poor, I'm afraid. So surgery wouldn't have really been possible because the size of the tumour meant it wouldn't be found reliably by ultrasound, which is the technology used for the surgery. So tomotherapy is a good option. Now that tumour, that new tumour, has been damaged a lot by chemotherapy. So when the new tumour appeared, I started chemotherapy again, having irinotecan and Xeloda and Avastin every 3 weeks, and they've done a very good job of tackling that tumour, but there'll almost certainly be cancer remaining there because chemotherapy is not usually effective at completely destroying tumours, particularly if it's cancer that's spread in your body. Those sort of tumours tend to be chemo-resistant, so that's why tomotherapy is a good option for the liver. So tomotherapy is a type of radiotherapy. I've had another radiotherapy before for my liver called proton beam therapy. Proton beam therapy is using heavy particles, protons, relatively heavy, I guess, and tomotherapy uses X-rays, also called gamma rays. So it's a type of beam radiation, and beam radiation has two problems. One is that it damages the tissue that's healthy, kind of before the tumour. And the other thing is, because it's a radiation beam, it goes on forever, so it damages the tissue after the tumour as well, which is called the exit wound. Now, the damage to the tumour before, the damage to the healthy tissue before the tumour is kind of serious, because that's where the radiation beam is the highest intensity. And obviously the radiation beam has to be a certain intensity so that there's enough intensity left when it hits the tumour, because it's, I guess the intensity drops quite a lot. If it was going through a vacuum, it would drop by the inverse square law, so you double the distance, and the intensity is going to drop to a quarter or a fourth, as the Americans call it. I would imagine the density drops much more rapidly going through tissue. And then you've got this this exit wound as well. So that's a problem. Proton beam therapy doesn't suffer from that because of the peculiar properties of heavy particles. When you fire protons or alpha particles, or I think you can do it with carbon atoms as well. They have unique properties in which there's almost no intensity before the tumour, and then intensity drops down to zero right at the back of the tumour as well, so it's very, very highly targeted. So tomotherapy, it's using X-rays or gamma rays, so how can they use that in a way that protects the tissue in front of the tumour and also minimise damage behind the tumour as well? So what they do is that the beams are split into, I think, thousands of beamlets, they call them, and so these beams are like spread over an area but are all angled so that they, like the focal point is in the tumour. So the healthy tissue is only going to get, a few tens of these beams going through it, which each are very low radiation, but the tumour itself, it gets several thousand focused at a point, and this should hopefully kill the tumour and or damage it, and then it will die naturally. And spare healthy tissue as much as possible. Generally, I think tomotherapy is regarded as a type of IMRT, which means intensity modulated radiotherapy, so they can vary the intensity of it. Some people refer to it as SBRT, which is stereotactic body radiotherapy, something like that. And they're both essentially marketing terms, regardless of what your doctor will tell you. So usually think of SBRT as things like CyberKnife, which is a similar treatment to tomotherapy. I think that they're both CT guided, so they do a CT scan every time you have treatment. Tomotherapy is a gantry system, so that means you're in a machine with like a donut kind of ring going around you, and the radiation gun or whatever it is going around that ring. Or maybe a tube is a more accurate description. So it's going around the ring, but the ring is moving on the tube as well. So you get the radiation is like delivered in a kind of spiral. A CyberKnife, instead of that, it's like a robot arm system. So there's a robot arm with a big head on it, and you lie there and it moves around you and shoots you from various angles. I believe CyberKnife is a little bit harsher. Also with CyberKnife, I think you can only treat visible tumours. So if the tumour is shrunk by chemo or whatever to smaller than where it can be seen on the scan, I think you can't treat that area, I believe, whereas for some reason with tomotherapy you can look at an old scan, use that for targeting. So tomotherapy is a supposedly gentle form of radiotherapy. The machine looks like a CT scanner, so you lie on a bed and you're sort of sent into this tube, and it actually has a CT scanner built in, so it does the CT scan. And there's also laser guidance, so it's kind of hard to explain, but before you go into the machine, you're lying on this bed, and when your tomotherapy is first being prepared the first time, the radiotherapy technicians will kind of draw all over you with pens. They get these pens out and they draw all over you to like make these marks that then can be seen by the laser. So you're lying there with these marks, and in my case, t-shirt off, the laser thing whizzing around looking for these marks, and then that's used to set the machine, and then you slide into the machine on this bed, and the CT scan takes a load of X-ray images of you, and then maybe the technicians come and like reposition your body a bit, they're sort of moving you around to get, because you're targeting things that are, the biggest tumour you're going to target is 30 millimeters. Now in my case, targeting a lung tumour that's 4 millimeters, some lymph nodes that are kind of 14 millimeters, I guess, the swollen lymph node. Very small targets, so you want to be really accurate in the positioning. And then you just lie there, and after 20 minutes or whatever, well actually, no, once you've had the CT scan bit, after about 5 to 10 minutes, they come and tell you it's over for the day. And then you come back the next day. So the radiotherapy is divided into fractions. So they take the total dose they're going to give you and they calculate these fractions. That's for 3 reasons, really. One is to let the healthy tissue recover. The other thing is to let the tumour reoxygenate. You want as much oxygen as possible in the cancer cells or around the cancer cells when you're doing radiotherapy, because the main mechanism of radiotherapy is that it knocks electrons off the oxygen atoms, turning them into free radicals that then go and damage the DNA. Just as, I guess, with sun exposure, you get the UV radiation from the sun forms free radicals and gives you the skin cancer. Similar mechanism. And the third reason is you want to catch the cancer cells just when they're about to divide, because again that's when they're very vulnerable. Because if you imagine, hopefully the radiotherapy has created some ions that's damaged the DNA, the cancer cell tries to copy itself, the immune system kicks in and says, look, you can't copy this damaged DNA, and kills the cell. So that's why you have this fractioning, or sometimes called hyperfractioning, because it's divided into so many treatments. And the only other thing to say about tomotherapy is, at least in Japan, you're kept still on the bed by like a 3D bumpy kind of mattress thing that's unique per patient. So when I went to prepare for the tomotherapy, for the liver and lung, for the lung and lymph nodes, and then later I had to go through the same procedure for preparing for the liver tomotherapy, I kind of lie down on this squidgy mattress. I think it's got some kind of sticky sand in or something, and you have a CT scan, they position you correctly, more CT scans, make sure you're exactly in the right position, and they suck the air out of this mattress thing, which it then keeps its shape, and then they write your name on it because it's unique for you as a patient. So that's the backstop. And as I said, I've done 6 weeks, so I've got 4 more weeks left. And I guess the only other thing to say that's very frustrating is that when it's finished, I have to wait a couple of months before having a scan. And the reason for that is that the radiation, attacking the tumours with the radiation, is going to cause inflammation in the area. So if you have a scan, it's not actually very useful. You wouldn't see it. You wouldn't know if you were seeing a tumour that had survived or an area of inflammation. It would be very difficult to tell. So unless the blood test kind of suggests other cancer in the body, then you have to wait a few months. So I'm not going to have my scan until November. While I'm on these 10 weeks of radiotherapy, I'm on a reduced chemo regime, but my immunotherapist is strongly recommending that after the radiotherapy I go straight back onto the brutal 3-drug treatment until my scan in November. I'm debating a lot on whether I should do that or not. He says he said it's his strong recommendation, but there's no good data to say whether it would be useful or not. It's just his recommendation based on, I guess, his experience and his knowledge, but it's not based on data. So I'm not sure if I want to do that horrific kind of it would be like 3 cycles of this combination drug stuff. So at the moment I'm just on the oral chemo called Xeloda. So I take 10 of these tablets a day. The reason I'm having trouble getting this in the right place is because Apple flip the image or rather they fail to flip the image because they're idiots. But 5 tablets in the morning after breakfast, 5 in the evening after evening meal, and that's for 2 weeks, then a 1 week break, and it will start again. And I take this drug daily. This is called metformin. This is a diabetes drug. I don't have diabetes, but it has been proven really to attack cancer stem cells, which are believed to form new tumours and are also strongly resistant to treatment. So metformin has a couple of mechanisms. So one is a metabolic mechanism, which kind of makes sense. It's an anti-diabetes drug. So, it's designed for people who have trouble with the metabolism of sugar. So the drug has some impact on the metabolism of the cancer cells, because cancer cells are poor at aerobic respiration and are forced to use anaerobic respiration, which is quite inefficient. And this drug interferes with the metabolism of those cancer cells and damages them and hopefully kills them. And it also, possibly as a consequence of that, it causes T cell activation. T cells are a type of white blood cell, and they're pretty good at killing cancer cells. I think one T cell can kill like 1,000 cancer cells before it itself has to die. So I don't know if there's something, if the drug is directly causing the T cells to come to the tumour, or if it, I guess it's more likely that drug is damaging the cancer cells through interfering with the metabolism, and that then causes the T cells to recognise there are these damaged cells there that need to be killed, or whatever. So, yeah, this was a longer and more detailed explanation of tomotherapy, but hopefully it's been useful for you if you have cancer yourself or know someone with cancer. These kind of advanced treatments like tomotherapy, CyberKnife, proton beam therapy, the emerging immunotherapies and hypothermia therapy, most doctors know very little about them. Most oncologists, so cancer specialists, know very little about them. So it's really important that you, find the top people and go and talk to them. When I first talked to oncologists about doing radiotherapy for my lymph nodes, they were saying, "Oh no, you can't possibly do that. You'll get internal bleeding and you'll die." They were not familiar with the newer, more gentle technologies. So I hope that's been useful. Please hit the subscribe button. When you subscribe, that makes a big difference, because these videos are seen by more people and hopefully will help more people. And if you've got time, I would just absolutely love to hear from you. If you could do a comment, that would be great. Thanks a lot. Bye.